Hello, my name is Daniella Mikhail. I am an internal medicine resident, currently doing my residency at Rutgers Robert Wood Johnson in New Brunswick, in New Jersey. I am pleased to be here to present my case report, which was recently published in ACG titled Bullseye Sign: Rapid Appearance of Diffuse Lung Cancer Metastases in the Stomach. Some objectives for this presentation is to discuss common sites of lung malignancy metastases and demonstrate that GI metastases are a rare finding. Second is to discuss common presentations of GI metastases. Third is to discuss a case displaying the rapid metastases of lung cancer to the stomach. And fourth, to learn key endoscopic findings of gastric metastases. So for our background, lung malignancies most commonly spread to the brain, liver, bones, and adrenal glands. It is uncommon for lung malignancies to lead to gastric metastases. However, when we do find gastric metastases, when looking at which cancers are most likely to cause gastric metastases, we do see an association with non-small cell lung cancer, and that is the second leading cause of gastric metastases. These metastases can present in numerous different ways. It can range from asymptomatic to abdominal pain, dysphagia, as well as GI bleed, which we will see with this case. So for our case, this is a 50-year-old male whose past medical history is significant for active smoking, who presented with worsening thigh pain and weight loss over the past 1 to 2 months. Due to his thigh pain, he underwent imaging, including an MRI of his lower extremity, which showed a 6.2 centimeter mass that nearly replaced the entirety of the femoral neck. This scan also displayed other bone lesions, which was concerning for metastatic disease. Given these findings, he underwent further imaging to determine what his primary malignancy was. On his CT chest, he was found to have a lung mass. He underwent a biopsy, which then showed invasive, poorly differentiated lung adenocarcinoma. With this new diagnosis of metastatic lung cancer, he was admitted to the floors for further management. On presentation to the hospital, he was also noted to have anemia with a hemoglobin of 5.8. His prior hemoglobin was 12 to 13. He did not report any overt bleeding, and there was no evidence of bleeding on his initial presentation. However, he was noted to have a positive fecal occult stool test, and therefore the gastroenterology service was consulted on admission. Due to his leg pain, the patient did report that he was having increased use of NSAIDs for his pain. The patient was given 2 units of blood for his hemoglobin of 5.8. However, he was not responsive to transfusions. Given this finding, as well as his increased NSAID use, the patient underwent endoscopic evaluation. His initial endoscopy showed gastritis, but otherwise was unremarkable. Of note, this was done May 16, 2023. The patient was started on a PPI and went back to the floors for further management. The patient's hospitalization then was complicated by sepsis, worsening renal failure, and an episode of melena. Due to the new melena, the GI team was reconsulted. In addition, he went into shock, likely hypovolemic, with a component of sepsis, and was upgraded to the ICU for pressors. Due to his anemia and his new melena, the patient underwent another EGD on the 2nd of June, 2 weeks following his initial endoscopy. This endoscopy showed diffuse nodule lesions in the stomach, esophagus, and duodenum. The findings were concerning for either HSV or malignancy. Biopsies were taken and patient was started on acyclovir following this endoscopy. Unfortunately, his overall state continued to decline during this hospitalization, and the next coming days the patient had worsening vasopressor requirements in the setting of refractory shock. The patient was then made comfort care after goals of care discussions were had with his family. After his passing, the biopsy results of his gastric lesions resulted and were positive for poorly differentiated adenocarcinoma, confirming that these lesions were not HSV, but rather lung malignancy metastases. The key point of this case report, and something important for us to take out of it, was 1, the rapid progression of the lung cancer and the gastric metastases. As mentioned previously, these two endoscopies were done 2 weeks apart, and there was a rapid progression in the gastric metastases. Also of note, something to take away, is how the gastric metastases appear on endoscopy. We would describe these lesions as bullseye lesions with central ulcerations. So in conclusion, gastric metastases can present as GI bleeds and they can appear rapidly. Endoscopic findings of gastric metastases may include mucosal nodules that demonstrate bullseye sign with central ulcerations. Thank you once again, and I'd be happy to take any questions.